Good evening, everyone. First of all, I must thank Smit for organizing this academic activity very regularly. And I thank the panelists, my seniors, my colleagues, for giving me this opportunity to talk on evolution of TAVI device designs, advantages. So by the end of this presentation, our aim is to know the key features of currently available transcatheter heart valves in India, know the major advantages and limitations of particular transcatheter heart valves, and be able to tailor transcatheter heart valve prosthesis to the patient clinical, anatomical, and risk profile and potentially improve outcomes. As you all know, TAVI is a disruptive technology. Despite great advancements in designs of TAVI valves, no single valve is optimal for all aortic stenosis patients, and tricuspid heart valves are still evolving, rather at a faster pace. If you look at the mind behind TAVI prototype, this is the man, Dr. Anderson, who in 1989 concepted implanting heart valves percutaneously by catheter without surgery. Short listening to a presentation by Julio Palms during USA. Palms was lecturing about how he invented and implanted balloon expandable coronary stents in animals. With this idea, he came back to Denmark, where he developed an artificial valve that was suitable for percutaneous implantation. This valve has a stent frame, which was made from steel wires, as well as some iron wires, which was stitched together using a thread. He harvested biological valve from the pig hearts, which were brought from a local slaughterhouse. And he crimped this stent with a biological valve onto a second-hand 30-millimeter balloon catheter that was pioneered by Crebier in 1980s. He somehow procured this balloon and mounted this stent valve over to that balloon. And this assembly was then inserted into a 41-millimeter introducer sheath, and consequently, first in animal implantation was done on 18th May 1989 using 3 rings as shown in the right top panel. These 3 rings stitched one over each other and a valve implanted inside it and mounted over a balloon. This was successful, and this whole from idea to proof of first concept took 2.5 months only. Although this was a promising results, but the device didn't have clinical applications because the large introducing system did not have allow implantation in humans because it was 41 French system. He presented his work in 1990 at a Danish Society of Cardiology, but his abstract submitted to 12th Congress of ESC in 1990 was rejected. He sent his work for publication in JACC and Circulation, which was again rejected. Finally, in 1991, his manuscript was accepted in European Heart Journal, which was a very low-impact heart journal at that point of time. His paper was published in 1992, 3 years after he had the idea of having a valve like TAVI valve. TAVI in humans credit goes to Dr. Alan Crebier, who pioneered aortic valvuloplasty in 1985. But was confronted with very high rate of restenosis. Anderson was working on the animal models, but Alan Crebier was working on the human cadavers, and he experimented with a stent crimped over a balloon in 1984. At that point, Alan Crebier as well as Anderson approached the industry, but companies were not interested as it was considered ridiculous, impossible, and unnecessary intervention. In 2002, Alan Crebier performed first-in-man implantation in an adult patient with severe aortic stenosis who was a 57-year-old male having cardiogenic shock, and he did it after balloon angioplasty, and patient survived for 4 months after that and died due to non-cardiac cause. Following this, he implanted balloon expandable valves in multiple inoperable patients. Simultaneously, a new self-expanding biological valve, that's core valve, was pioneered by French cardiac surgeon Professor Sanguin in 2001. From 2002 onwards, TAVI journey occurred at a very fast pace, and it didn't look back, starting with inoperable and extreme high-risk patients, getting approvals because of the evident efficacy in comparison to surgery in high-risk patients, then in intermediate-risk patients. It got approved in low-risk patients of aortic stenosis more than 75 years of age, whereas ACCHA guidelines recommend it even in patients more than 65 years of age. So with this expanding approvals, the TAVR volume all over the world, particularly with the US data, has gone up. The number of indications expanded, sites performing TAVR increased over years, as well as the outcomes got better with years. All these events led to an increasing volume of TAVR procedures and continuous extension of population deemed suitable for TAVR. With this, there was an impressive constant evolution of TAVR devices and materials, and we had a wide range of bioprocesses with different dimensions, designs, deliverability, providing opportunity to select a device based on each patient's clinical and anatomic characters. Further, expanding clinical indications for TAVR into younger patients, patients with bicuspid aortic valve, patients with bioprosthesis, degeneration, as well as patients with AR, created a need for devices with specific features. So with this, we have lots of TAVR devices available. There are like 4 types of devices available. One is the balloon expandable devices, self-expanding devices, mechanically expandable devices, and valves with active fixation mechanisms. The self-expanding devices are of 2 types. One which have the supraannular valve and have intraannular valves. The balloon expandable valves available in India include SAPIEN 3 and MyValve transcatheter heart valve. SAPIEN 3 is a quad chromium and is available in sizes ranging from 20 to 29, and it's an intraannular valve and is compatible with 14 French system. And MyValve is a nickel cobalt alloy, and it has bovine pericardium and is available from sizes 20 to 32 and is compatible with 14 French system. And this is also intraannular. So both the valves are almost similar. SAPIEN 3 Ultra is available in Europe, but it's not yet available in India. It's likely to be possibly available in near future. Regarding the self-expanding valves, there are more than 20 valves available all over the world. What we have available in India is the core valve family. From the core valve family, we have Evolut R, Evolut Pro, and Evolut Pro Plus. Evolut Pro is going to be phased out soon, and we left with Evolut R as well as Evolut Pro Plus. From the Boston, we have Accurate Neo 2 available in India, and another valve available in India is Hydra. All these 3 valves are supraannular valves. They're self-expanding. They have porcine pericardium valve, whereas Hydra has bovine pericardium. Evolut R and Accurate Neo are compatible with 14 French systems, whereas Hydra requires 18 French system. And Evolut Pro and Hydra are repositionable and retrievable, whereas Accurate Neo is not repositionable and is not retrievable. And all are suitable for transfemoral approach. Then another 2 valves, which are also self-expanding valves, is Portico and Navito. They are different from previous valves in that these 2 valves are intraannular rather than supraannular, and they have bovine pericardium valves, and they are available in sizes varying from 23 to 29. Both are almost similar and are from Abbott. Navitor is a newer like addition to Portico. The mechanical expandable valves, that is Lotus and Mantra, they are not available as of now. They are really very good valves, but were withdrawn because of the very high pacemaker rates, as well as the issues with their delivery system, and are not available anywhere in the world as of now. Some of the valves are being developed for active fixation, particularly for patients with aortic regurgitation. These are Jena valve and J valve. These 2 valves have active fixation mechanism because patients with isolated aortic regurgitation often do not have much calcium. And these 2 valves are intraannular and are Jena valve is available in Europe, but is under investigation in the US, but is not available in India. J valve is again under development. Despite these technological advances and availability of wide range of devices, adverse events are common. A knowledge of these prognostically important events would enhance our understanding in selecting a device with specific features to optimize patient outcomes. If we look at the events which are associated with TAVI, stroke, clinical coronary obstruction, patient processes mismatch, clinically significant paravalvular leak, vascular complications, and conduction disturbances are the most common issues after TAVI, and really concerning because they are all associated with increased mortality and morbidity. Further, with expanding indications to younger patients and low-risk patients, our metrics are also expanding. From like previously, we were more worried about stroke and mortality, quality of life, and conduction disturbances when we were dealing with like high-risk patients, patients who were 80 plus, and patients who had low activity, and patients who had leaflet valves. Now we are adding more patients to it with expanding indications to low-risk patients, patients who have coronary disease, patients who are more than 65 years of age. We are involving more and more bicuspid patients, particularly in India, and patients need to do more activity. So we are more concerned about hemodynamics and patient processes mismatch, durability issues, life expectancy, and coronary excess in future after TAVI. So our focus is now shifting from only mortality to be more inclusive in the management of such patients in future. Understanding of advancements in transcatheter heart valve device designs and its delivery system have potential to reduce these adverse events and optimizing future management. Currently available balloon expandable valves in India include SAPIEN 3. SAPIEN 3 Ultra is not yet available, but possibly will be available soon, and MyValve. Regarding the self-expanding valves, as already discussed, we have Evolut Pro, Evolut Pro Plus, Accurate Neo 2, Portico, Navitor, and Hydra. If we look at the evolution of Edwards SAPIEN, the valve sizes have increased. Initially, to start with, there were only two sizes, 23 and 26, and at present we have four sizes available, which is 20, 23, 26, and 29 millimeters. The leaflet geometry has been improved with anti-calcification treatment of these leaflets, which resists structural valve degeneration. The frame composition has changed. The frame from like earlier it was stainless steel, now it has been changed over to cobalt chromium alloy, which is thinner studs but still maintaining strength. The frame geometry has also improved with the upper cells becoming more larger for better coronary access in case it goes, it's deployed relatively higher. And there is a cuff around the lower cells for preventing aortic regurgitation, which is also a recent addition. Further, the sheath compatibility has decreased from 24 French to 14 French, and delivery systems have improved a lot over a period of time. So this is the evolution that we observed in SAPIEN 3 valve. Now we have Ultra, which is not yet available in India, but likely to be available, has a polyethylene skirt that is 40% higher compared to SAPIEN 3, which is currently available in India. And this has shown to be significantly reduce the incidence of PVL. Further, SAPIEN 3 Ultra Resilia platform also extends PVL to 29 millimeter valve, which was not available in SAPIEN 3 Ultra otherwise. And anti-calcification treatment of these leaflets prevents calcification and structural valve degeneration. If we look at the data, real world data, we see that these advances, they help in reducing paravalvular regurgitation at discharge from 0.4% with SAPIEN 3 to 0.1% with Ultra. I mean, moderate or more than moderate paravalvular regurgitation, they reduce from 0.4% to 0.1% in Ultra. Mild or non-regurgitation remained, mild regurgitation was 13% versus 9%. And most of the patients with this advancement with the addition of this PET skirt had no aortic regurgitation, paravalvular leak at the time of discharge from the hospital. So with Edwards, we have a wide range of advantages include, we have a wide range of valve sizes. And even some people do extend it off label by adding some more like saline or contrast to it. And valve leaflet geometry has been optimized. Frame composition has been improved. Frame geometry provides easy access to the coronaries. And PET skirt provides protection against paravalvular leak. And there's an improved delivery catheter, which is 14 French or 16 French, which helps in reducing vascular complications. Further, there is a less tube graft potential if repeat TAVI is needed. So balloon expandable valves are one of the favorite valves in case repeat TAVI is needed after degeneration of balloon expandable valves. We can easily go ahead with supraannular valves. Further, they have lower pacemaker rates in comparison to self-expanding valves. But the limitations of Edwards Sapiens include it has a large, it's like not very much favorable for large annuli, more than like 29 millimeters size. It's not available. It's not repositionable, not retrievable. It has relatively small effective orifice area in comparison to self-expanding valves, and there is a potential for PPM. It needs pacing, so may not be suitable for patients who cannot tolerate pacing, like patients who are have severe elbow dysfunction. And being a balloon expandable valve, there is a risk of annular rupture in patients with severely calcified annulus. The next valve of this category is my valve. My valve is almost same as Edwards Sapiens valve, and it's made in India by Merrill, and it has got hybrid honeycomb cell design. Approximately 50% of the frame height is covered with closed cells, and 53% of the frame height is open cells for better coronary access. Other features are almost the same. It has also anti-calcification treatment of the leaflets to prevent degeneration. The additional feature of this particular valve is that it's available in sizes varying from 20 millimeters to 32 millimeters, which is a wider range in comparison to Edwards valve. And the increments that we get is 1.5 millimeters in my valve in comparison to Edwards, where we get 3 millimeters increments. So we have wider range of sizes available with my valve in comparison to Edwards. This particular appearance, like cell size or the honeycomb pattern of the cells, gives it this particular valve a particular appearance. And this is quite helpful in implanting the valve because we aim to keep the second dense band at the level of the annulus. This is quite helpful because here we have markers, the dense band on the valve itself, rather than Edwards. In Edwards, our focus is on the marker, which is rather on the balloon rather than the valve itself. So sometimes what happens, the valve goes up and down a little bit. So our marker which we usually follow is on the balloon. So it may help, it may sometimes cause issues with the positioning of the valve when deploying it, which is not with my valve. Now the my valve has improved its design, and now currently available is octa-core my valve, transcatheter heart valve. And what they have done changes in this particular valve is from 3-cell design. Earlier there was 3 cells in height. It has changed over to 2 cells, 2 row of hybrid interlaced octagonal cells. Earlier they were hexagonal cells. Now they have octagonal cells, which are larger, and larger cells also provide better coronary access in case of future interventions. And the sizes available remains the same. And there is a additional PET skirt to plug the PVLs. So this valve is an improvement over the existing my valve and provides better opportunities for future coronary access. So this octa-core valve supports fatigue-free performance. It is optimal effective orifice area and provides low gradients and significant elimination of clinically significant PVL, and thus positively influences survival. And because it is deployed 3.5 millimeters or less in depth into the LVOT below the annulus, the chances of having conduction disturbances is very low, which otherwise is also low with the balloon expandable valves. And it provides at least a 6 millimeter access to the coronaries, which is quite larger in comparison to our Edwards valve. And the foreshortening while deploying is quite low in octa-core in comparison to Edwards, as well as in comparison to Evolute Pro. It's only 19 to 20% versus 26% and 44% for Edwards and Medtronic Evolute Pro. So this is because of the octagonal cell design in octa-core. So the positioning of this particular valve would be better during deployment. It won't change much. Whereas the Edwards valve usually shrinks from velo, from the LV cavity size, and moves a little bit up when you deploy it, when it expands. Further, there is a commissioner alignment is also in the pipeline for this particular valve, and it's possible with this particular valve using the technique which they have pending patents. Now, the self-expanding valves available in India include these 5, as we have already discussed. Accurate Neo is a valve which is from Boston, and it has Accurate Neo is not available. Accurate Neo 2 is available. This particular valve has a nitinol frame. It is self-expanding. The peculiar feature of this particular valve is that its deployment is a 2-step deployment, and it's top-down deployment. But its radial force is relatively low in comparison to the Medtronic valve. So the chances of injury and pacemaker rate is low, but at the same time, sometimes if you require a good radial strength, it may not be that suitable. But it's a good valve, very flexible, and the deployment is really nice. And you need not to pace with this particular valve because you have to, like, it occludes the LVOT or aortic flow only when you open the knob 2, which is a 2-second job. Otherwise, it doesn't require pacing. It's a supraannular design, and it has stabilization arches, which help in facilitating coronary access, as well as alignment of the valve to the native annulus. And the upper crowns that we see just above the blue line in the middle, these are upper crowns. These upper crowns, they sit over the leaflets and anchor over the leaflets. And this is where actually most of the anchoring with this particular valve take place. And it prevents against coronary obstruction. There's a pericardial seal at the base, which protects against PVL, and lower crown minimally protrude into the LVOT. So the chances of conduction disturbances are much lower in comparison to other self-expanding valves like Medtronic. The one thing to remember with this particular valve is that it has maximum radial force 5 millimeters above the lower end. So this particular area should be at the level of the annulus. So implant depth is approximately 5 to 7 millimeters. And we should aim to keep this area where we have the maximal radial force at the level of annulus. This will help in minimizing the PVL because it will seal better. This will help in anchoring the valve better, and also doesn't cause conduction disturbances because it doesn't really go or have a very high radial force, which causes obstruction or impinges onto the bundle of his or left bundle. And no pacing is required. So this can be a useful strategy for patients who have severe LV dysfunction. And we have 3 sizes available. 23 millimeters is small, medium, and large is 27 millimeters. And its selection of this particular valve is based on the perimeter rather than area. And the delivery system of this particular valve is 14 French, which is highly flexible. This valve actually is much more flexible in comparison to the valve from Medtronic, the Evolute Pro, and it goes anywhere into the horizontal anatomies, into the tortuous anatomies, and it has a eye sleeve, which is like expandable sheath, and it really goes very easily, and you need not to push it hard like we do it with Edwards or with my valve. It goes very easily. And the rates of PVL with Accurate Neo are really low, to the tune of 2.7% in comparison to the previous model, which was Accurate Neo, where it was 9.4%. I mean, the incidence of severe PVL. Otherwise, moderate PVL mild PVL is or no PVL is it doesn't matter. Medtronic valve is the core valve family, started in 2009 and with core valve. Then Evolut R came in 2015, then Evolut Pro in 2017, and now we have Evolut Pro Plus available with Evolut Pro Plus delivery system. Evolut Pro Plus has two features in addition to the previous Evolut Pro valve. It is a low profile delivery system which just requires 5mm vessels for 23 to 29mm valve. And for 34mm valve, it requires 6mm. And there is a sealing skirt which is available on all the valves in addition to 34mm valve. So this protects against PVL and has a good delivery system which can be easily go through 14 French sheath. And it's available in sizes varying from 23, 26, 29, and 34, and covers an annulus from 18mm to 30mm, which is widest in range in comparison to other self-expanding valves. So whenever we need a larger valve, we think of going into Evolut Pro Plus or Evolut Pro, whatever. So advantages of this valve is that it's suitable for wide range of annulus sizes. It's repositionable. It has a good radial strength, better PVL seal, achieve good commissural alignment. It has a better hemodynamics because the valve is supraannular and it provides a really good effective orifice area. So better hemodynamics means slow degeneration, longer life of this particular valve, and it's 14 French compatible. But the disadvantages include it has relatively higher conduction disturbances in comparison to other valves, and it has a high frame height, which we need to think about coronary access in future. This is the next generation like Evolut FX system, which is available in US, but is not available in India as of now, and will be, I think, reaching India very soon in next 1 year or so. This is a like better delivery system and a better valve where we will have markers on the lower end. These markers will help in better commissural alignment, as well as they help controlling the depth of implant, which is really required with this particular valve because the pacemaker rates are relatively higher in comparison to other valves. And the delivery will be more stable and more predictable with this Evolut FX system. And of course, the TAVI commissural alignment is better, will be better. Another valve is Portico, which is Abbott from Abbott. It's a self-expanding valve, fully repositionable and retrievable up to 85% deployment. It has bovine pericardium and porcine pericardial sealing cuff. There is a leaflet location, it's annular. It is intra-annular valve in contrast to the other valves like which was supra-annular. It doesn't cause hypotension during deployment, and rapid pacing is not required while deployment. And it's available in sizes varying from 23 to 29. If you look at the cell size of Portico versus Evolut Pro, the cell size, particularly in the upper area, is 20 French, whereas in Evolut Pro, it is 11 French. So it really provides a very good access to the coronaries in contrast to Evolut Pro, which has some limitations, particularly in young patients. So coronary access is better preserved with this particular valve, and it covers an annulus size varying from 19mm to 27 and is available in 4 sizes. The currently available is Portico FlexNav, which is improved delivery system in comparison to the previous valve, which has helped in better positioning and preventing peripheral vascular complications in comparison to the previous valve available, as well as the pacemaker rate has come down in comparison to the previous Portico valve with this FlexNav delivery system because of more accurate position. Navitor is another valve. This is just a valve which is again from the same company as Portico, and it's similar, almost similar to Portico, but it has like curved aortic cells which prevent injury to the native structures, as well as it has outer and inner Navi seal cuff, which helps in protecting against PVL. Large cell design as in Portico, and annulus size treatment is treats about 19, starting from 19 millimeters to 27 millimeters annular diameters. And this particular valve has been tested to be to function in a circular as well as elliptical configurations, because we know sometimes an aortic valve is not a circular structure, and this valve has been shown to tested to be working in elliptical as well as circular configurations very well. And it has a delivery system which is 14 French compatible and is consistent with 5 millimeter minimum vessel diameter. Again, 4 sizes, and 23 and 25 millimeters are compatible with 14 French, whereas 27 and 29 millimeters are compatible with 15 French system. The last valve available in India is the Hydra. It's from Saujatya Medical Technologies, and this particular valve has varying radial force, with high radial force in the lower end and low radial force in the upper end, so providing a better seal and at the same time avoiding injury to the aorta or other structures. So there is a less metal at the upper outflow tract, and it's a large cell design which is provides better coronary access. And at the lower end, there are radio-opaque markers for accurate positioning, and the lower end of this particular valve is not flared. It means even if it goes into the LVOT, and LVOT is relatively larger, it doesn't cause conduction disturbances, or is potentially to cause less conduction disturbances in comparison to the core valve, which is you can say flared at the lower end. And large frame cells provide easy access to the coronaries, and there is a sealing skirt which mitigates paravalvular regurgitation. And this valve is recapturable, retrievable, and repositionable up to 80% deployment, and is 14 French compatible, available in 3 sizes, and covers an annulus starting from 17 to 27. So these are the 5 valves which are available. So in nutshell, if we look at the balloon expandable valves, these valves have lower stent frame height, which facilitates coronary access in future. It has a steerable delivery system, which is good for challenging anatomies, as in case of tortuous vessels or in case of horizontal aorta. However, it requires rapid ventricular pacing, so may not be suitable for patients with low ejection fraction. All balloon expandable valves are intra-annular, and the intra-annular position of the valves has been shown to have relatively inferior hemodynamics in comparison to the supra-annular valves. So there's no strong data on that, and balloon expandable valves do work well in the intra-annular position, and these valves is not repositionable. On the other hand, self-expanding valves are supra-annular. They provide larger effective orifice area, lower gradients, and lower rates of patient processes mismatch. Lower gradients, better hemodynamics also mean slow structural valve degeneration. These valves are repositionable, retrievable, and they are also good for patients who are at poor tolerance to rapid pacing, because some of these valves do not require pacing. They are supra-annular design. They are good for small annulus as well as severely calcific annulus, and they are good for TAVI and SAVI, valve in valve. But the limitation of these valves is that they have a longer frame, so coronary access may be challenging, which is taken care of with the changes in design of the recent valves with larger upper cells, and they have a limited steerability. Other 2 valves, mechanically expandable valves, as we already discussed, they are not available as of now because of the recall due to product issues with product delivery system. And some of the valves with active fixation are under development, and this particular valve is available in Europe, what is under investigation in UK. This is particularly suitable for patients with aortic regurgitation, and it fixes over to, this is Jena valve triology. It fixes over to the native leaflets, and its active fixation mechanism, and aligns itself to the native cusps. So commissural alignment is not an issue. and it has a large cell design to access coronaries very easily. So this is the valve for actually for aortic regurgitation. Another valves is J valve, as well as some Chinese valve being developed for particularly for bicuspid anatomy. So what are the implications of these TAVI device designs on prosthesis selection in TAVI? As we all know that one device doesn't fit all. We need to tailor our devices according to patient's anatomy and patient's clinical factors. If we look at the aortic annulus, the sizing of these bioprocesses is done depending on the size of the annulus and aortic root dimensions. Most of the devices are available from 20 to 29 millimeters with 3 millimeter increments. But my valve, as we have already discussed, is available with 1.5 millimeter increments, and the diameters range from 20 to 32. So we have a benefit of having smaller rises, smaller increments, and up to a wider range of valves, balloon expandable valve. That's my valve available. Now, if we have to oversize, we need to oversize all these valves, but to some extent. But if there's a risk of annular rupture, suppose the annular dimensions fall between two valves, the choice we have is to use a larger valve to have a better hemodynamic performance, or use an undersized valve, which will have a relatively inferior hemodynamics, but the risk of aortic root injury will be low. In such cases, it's better to use a valve, undersized valve, maybe some extra mLs. It's a valuable option because the risk of annular rupture and its associated mortality is very high in comparison to the hemodynamics, concern for hemodynamics. So what if we have a small aortic annulus or a large aortic annulus? A small annulus is defined as a perimeter less than 72, area of less than 400. It's a well-defined risk factor for patient processes mismatch, particularly in patients with large body surface area. Supraannular valves are better in such a situation because they provide better hemodynamics, better effective orifice area, and they have less ppm in comparison to intraannular valves, although there is no difference among various supraannular valves. In large annulus, more than 575 millimeters in area, or more than 85 millimeters in perimeter, we have very limited choices. We are left with two valves, that is Evolut R to 34 millimeters or Sapien 329 millimeters. But in India, we have my valve also available, which is a good choice for large annulus also. The Tower large registry has shown that, which is compared Sapien 3 versus Evolut transcatheter heart valve in large annulus, have shown that valve embolization, need for second valve implantation, and PVL occurred more frequently with Evolut R in comparison to balloon expandable valve. So overall, balloon expandable valves are preferred in patients with larger annulus. And another valve is Navitor Titan valve, which is a valid potential alternative among the self-expanding valves for large annulus, but this particular valve is not available in India as of now. Severity of calcification again makes a difference. If it's a severe leaflet calcification, there is a risk of incomplete prosthesis expansion. In such patients, balloon expandable valves are often considered a first choice to overcome associated high resistance. Otherwise, if we are going to implant a self-expanding valve, or self-expanding valve is indicated in such a situation, pre-dilation and or post-dilation is compulsory. Otherwise, with the leaflet calcification only, balloon expandable valve should be the first choice. But what if there is a severe annular, alveoli, or sinotubular junction calcification? In such patients with balloon expandable valves, there is a high risk of annular rupture, aortic dissection. In such patients, we need a valve, a self-expanding valve with lower opening force. In such patients, we may either go ahead with Evolut Pro or Navitor, maybe a valid choice in such patients. What if the aortic root anatomy is at risk of sinus sequestration or coronary obstruction? This is particularly common in India and particularly in women because our patients are relatively smaller and they have low-lying coronary ostia shallow and shorter sinuses of Valsalva, or this also happens in patients who have previous surgical aortic processes, dysfunctional processes, now for valve and valve. In such patients, specific features may help reduce the risk of coronary obstruction, because major risk in such patients is coronary obstruction. So the valve which is beneficial in such a situation is accurate neo or neo 2 stent frame, where the upper crowns of this particular valve hook onto the native leaflets, which may restrict the movement of native leaflets towards a coronary osteo. So if there is no really very hard calcification, accurate neo is the choice for such patients. In bicuspid aortic valve, it's a different story. And the issues with this bicuspid aortic valve patients include larger annular dimensions, more extensive calcification burden, asymmetrical orifice, and coexisting dilatation of aortic root. With this anatomy, we have increased risk of stroke, significant PVL, device migration and embolization, as well as annular rupture. In such patients, the device, there's no particular device suitable for or particularly dedicated to bicuspid aortic valve. We have to see other factors also taken into consideration when we're deciding the type of valve for such patients. Although newer generation balloon expandable valves and mechanical expandable valves are likely to perform better than self-expanding valves in these patients because of the greater radial force during valve expansion and more uniform expansion in asymmetric anatomy. So reducing the risk of PVL and with a high device success rate. The Lotus and Lotus Edge has particularly suitable for this particular anatomy, but they are not available as of now. In patients who are at high risk of annular rupture, self-expanding valves may be considered, but the risk of significant PVL may be higher. Now, China is developing two valves, that is venous A valve and pitta flow valve, as well as another valve is Taurus 1 valve, which is particularly dedicated for bicuspid anatomy, but these valves are not available in India. So as of now, there's no clear guidance on which processes to choose in this setting. Then another factor to be considered when choosing a prosthesis is the age and life expectancy, which is a very important consideration, particularly if we are moving into low-risk patients and young patients, where we have concerns regarding future coronary access. We have concerns regarding pacemaker implantation. Future coronary access, as we have already discussed, is better with small stent frame, like balloon expandable valves, as well as intra-annular valves. The future coronary access is better. So balloon expandable valves perform better in such a situation. As well as the pacemaker rates are better, much lower with balloon expandable valves in comparison to self-expanding valves. So balloon expandable valves are the first choice in young patients to prevent the risk of pacemaker implantation, because we all know that pacemaker implantation in such patients after the procedure is associated with long-term recurrent hospitalization as well as increased mortality. If self-expanding valve is required in such patients, it's better to use a valve with low radial strength and limited extension to the membranous septum. Accurate neo is a good choice. Again, the vascular complications. If we see at the designs of vascular access delivery systems, earlier it was 24, now have reduced to 14 French systems. So the diameter of currently required for most of the transfemoral tower devices is 5 millimeters. But the development of expandable sheaths has really facilitated this. Like we have eye sleeve sheath from Boston, as well as other expandable sheaths, which help us in using this much diameter for delivery of 14 to 18 French delivery valves. In the presence of significant tortuosity, calcification, or horizontal aorta, it's better to use this flexible delivery system, valve with a flexible delivery system like Sapien 3, or even my valve is a good choice in such patients. Horizontal aorta is the aorta where we have aortic angulation of more than 60. At this time, Sapien 3 should be considered as a first choice in such patients with horizontal aorta, or same for my valve, while accurate neo and portico are reasonable choices if contemplating a self-expanding valve or a supraannular device in such a situation. So if we have tortuous anatomy, balloon expandable should be the first choice. If self-expanding valve is required, accurate neo is a good choice. Conduction disturbances, as we have already discussed, they are in patients who are at risk of conduction disturbances, like patients who have alveolar calcification, patients who have annular calcification, patients who have pre-existing right bundle branch block, or other conduction disturbances. These patients at risk are served better with balloon expandable valve rather than self-expanding valves. But if a self-expanding valve is required, again, a self-expanding with low radial force is better. Navitor is another valve which has a tubular design, non-flaring design at the lower end, and have potential to reduce conduction disturbances. Another important issue in these patients is the technique of implant. So higher implants has been shown to reduce the pacemaker rates. This is particularly true for Evolut Pro, where Evolut valves, where cusp overlap technique facilitates higher implant and is likely to reduce the rate of pacemaker implantation in such patients. Another consideration is the length of the membranous septum during device implant and while in device selection. If you look at what is membranous septum, membranous septum is just below the right and the non-coronary sinus. At the lower end of the membranous septum, the left bundle, the bundle branch crosses, bundle of his crosses, and the left bundle lies there. And it is here that most of the valves projecting into the alveoli impinge upon to the left bundle and cause heart blocks. So our target should be, we can easily measure this membranous septum length from CT. And if the the depth of implant is less than the length of the membranous septum, we really avoid impinging upon to the left bundle, and we can really reduce the rate of pacemaker implantation in such patients. This is a MEDAS approach where they have evaluated patients who are at low risk or intermediate risk or high risk for pacing based on the length of the membranous septum. Length of the membranous septum, if more than 5 millimeters, it's a low risk. 2 to 5 millimeters, it's an intermediate risk. Less than 2 millimeters is a high risk for pacemaker or conduction disturbances after implant. What they have seen is that if the depth of implant is less than the length of the membranous septum, you hardly get conduction disturbances to the tune of 3%, which is same as that of the surgical valves. So we can really reduce pacemaker rate by adjusting of depth of implant. Another concern in patients with severe LVT is the pacing. RVP is rapid ventricular pacing is mandatory during balloon expandable valve implantation, and patients with severe LV dysfunction may not tolerate this. Our choice depends upon which type of valve otherwise the anatomy requires, and whether both the valves have their own pros and cons. Balloon expandable valves have a shorter procedure time, but they will require pacing. The self-expanding valves like Accurate Neo or Navitor, they do not require pacing, and they may be suitable if the patient is really cannot tolerate pacing. But believe me, balloon expandable valves also do a good job in such a situation, even if the be paced for a shorter period of time. Future coronary access is another issue, particularly with expanding indications to low-risk patients. Here, the factors which we should take into consideration while choosing a prosthesis is the frame height, the cell size, particularly the upper part of the where we have the coronaries, leaflet position, and commissural orientation. The frame height, we all know that is better with the balloon expandable valves than self-expanding valves, and supraannular valves are the worst, are the most problematic. So balloon expandable valve is currently the ideal prosthesis for optimal future coronary access. Or we can, if self-expanding valve is indicated, we should use a self-expanding valve with large cells, wide stabilization arches, or the one with intra-annular leaflets, such as Portico, Navitor, Accurate Neo, or Hydra. They also preserve good coronary access. Somehow this core valve has small cell size and has a larger frame, and future coronary access is relatively difficult with this particular valve, but still is possible because a commissure alignment is another issue. If we are able to align the commissures, then possibly we can access the coronaries even with core valve. In core valve, commissure alignment is one which we can really achieve a good success for commissure alignment with core valve. So commissure alignment does improve the selective coronary access, whatever the valve we deploy. Although it's not as important in balloon expandable valves, but it's more important for self-expanding valves. So if we look here, it's a mal-aligned transcatheter heart valve where the commissure is facing just the left coronary artery. And so if the BTC valve to coronary distance is less than 4 millimeters, in such patients, the repeat intervention with a transcatheter heart valve would be really difficult. But no doubt, Basilica is available. Basilica is a technically demanding procedure, but as such, this commissural alignment could have prevented this. So if we really want to understand how to do commissural alignment, first of all, we should understand that if we overlap the right and the left coronary sinus, the commissure between these two sinuses, which is like there's an arrow onto the right side. This is the commissure between these two sinuses. If we are able to find out the angle from the CT, where we can achieve this, with this commissure pointing towards the inner side of your aorta or the inner curvature of the aorta, then commissure alignment can be achieved, provided we know the landmarks on our valve also. So commissure alignment can be achieved in two ways. One is the passive commissural alignment, where we just look at the flush port of the device and go in and see whatever we achieve. For the Evolute Pro, we keep the flush port at 3 o'clock. For Accurate Neo, we usually keep flush port at 6 o'clock position. So the prerequisites for this is known as another is active commissural alignment. For active commissural alignment, we need to know is where are the native commissures, how they are oriented, what is the orientation of transcatheter heart valve commissures, and how can we align these two. For Accurate Neo, there is a technique of commissural alignment which is relatively easier to understand. As we all know that if we go at 6 o'clock position, when we go inside, we go to the 3-cusp view. So in the 3-cusp view, if we see the valve and we are getting 1-1-1 configuration, means these are 3 commissural posts on the top. If you see the figure with 1-1-1, there are 3 commissural posts, 3 lines. These 3 lines, if they are separated well, uniformly separated, it's 1-1-1 configuration, and there are 2 free cells just below that. This is a very good position. And after this position, we go to the cusp overlap or step 3 to confirm that we are aligned well. Here, we need to see a 1 free cell onto the inner curvature of the aorta, where the commissure between the right and the left coronary sinus lies. And if we use this technique, we are aligned to the commissures. What if it's not a 1-1-1 configuration, if it's 1:2 or 2:1, then we need to rotate our valve in the counterclockwise or clockwise position, depending upon what we have at the time of imaging. So what we need is in the 3-cusp view, 1-1-1 configuration, and the cusp overlap view, 1 free cell on the inner curvature of the aorta, we are aligned. Similarly for Evolute Pro, we need is the hat marker. Again, 3 o'clock position, we go in, hat marker on the outer curvature of the descending thoracic aorta. And then again, hat marker on the outer curvature of ascending aorta, and C-tab onto the inner curvature of the aorta, facing the commissure between the right and the left coronary sinus. With these techniques, what we see is that most of the times accurate neo is aligned very well with less than mild commissural alignment in 100%, with less than like it's really well aligned. Whereas Evolute Pro is aligned 90% of the times, and Portico is aligned 75% of the times. So accurate neo really aligns well to the commissures in comparison to Evolute Pro also. But even if Evolute Pro, it's not bad, it's 90%. Commissural alignment is really good, and we can really achieve it very easily in the lab if we know the technique. So in the end, I would like to say that we need to know our tools is crucial to device selection for a particular patient. When valve doesn't fit all, and patient's anatomical and clinical factors should be taken into consideration when selecting a device. And every lab should have at least one balloon expandable valve and one self-expanding valve. On to the left, there is a beautiful diagram, beautiful flow chart kind of thing, which includes like potential complications, expected complication in a particular patient. On the top, it's patient anatomy, whether patient's annulus is calcified, small annulus, or large annulus, extra large annulus, or it's a bicuspid valve. On the right side, these are the features which the particular valve has, like limited opening force, or patient, it's a supraannular design, or a low radial force, or frame design is short or large. These three things help in deciding us which valve to choose. At the lower end, we have 5 valves which are available in India. And with this particular network, we can choose our valve relatively accurately. Although this is not everything, but still we can choose our valve quite accurately. This particular picture was posted by Dr. Hazara in our group. Thank you, Dr. Hazara, for posting this. And it's really a wonderful picture. Yeah. Thank you for your precious time and patience.
Very, very exhaustive, and I think you covered pretty much everything. Dr. TP, would you like to start the discussion?
Yeah, really very good presentation, Prabandar. Congratulations.
Thank you,
and congratulations also for doing your first case in PGI, which you mentioned, OEF and kyphoscoliotic spine. So really good.
Thank you, sir. Thank you.
Yeah, it's a very good presentation, and you have very nicely explained the evolution of TAVI devices. So now we know that TAVI has now revolutionized the management of severe aortic stenosis. And since last 20 years, we are seeing, and it has now become the standard of care across the entire spectrum of surgical risk, and from high risk, inoperable, high risk, then intermediate, then now also entering the low risk. So I would say that we are the biggest enemies of the surgeons. Like a pitch, a ground, all created by surgeons. Initially, we were just doing fielding, then we started doing bowling. Now we are batting, bowling, and left the surgeons to just for fielding only. So yeah, that's there. And for TAVI, our endeavor in treating the younger, low risk patients, those who have longer life expectancy, and treating earlier in the disease process, naturally we need very fine devices where all the risk of complications like risk of pacemaker, risk of PVL, annual rupture, they all should be near minimal. So that's why there's all evolution in the design is going on. So procedure complications also coming less, sheath size also coming down and down. Initially it was 24, now up to 14th it has come. So like Edwards, they have come with the new thing which you mentioned, that anti-calcification, this is a cilia tissue, which is a bovine pericardial tissue, which is actually anti-calcification, which decreases the chances of structure valve degeneration. So things are coming and coming, like you said that this for Medtronic new delivery system like this Evolute FX and their new devices, this latest one is this Pro Plus.
Yes. Yeah.
So they are improving and improving. Even Sapien Ultra, then even this X4 is also coming. So designs are improving. Like for Manual, you said there's new after MyWall, there's Octra, which is also a very good for decreasing chances of complications.
Yeah, what is happening these days is that like if a particular study on a particular valve is started, it doesn't complete. The next version of that or next iteration of particular valve is available before a study is completed. So,
so even we have not tested the other device and another new device comes. Really great. So what do you think if patient has underlying right bundle branch block? So do you put the pacemaker first and then do the device, or still you wait to be done after the device, after the TAVI device?
In the presence of right bundle branch block, I don't think we should permanent pacemaker beforehand. In such patients, what we should, I think, do is it's one thing is that it's better to avoid a self-expanding valve in this particular situation, if possible, because balloon expandable valves really don't do much harm. I would after the procedure or during the procedure, yes, in such patients, I would be more careful and put a temporary pacemaker always, whatever valve we deploy, because temporary pacemaker rather than pacing on just the safari wire, it's better to put a proper pacemaker in such patients. And I will be more careful during the procedure to avoid a deep implant. High implant has shown to be really beneficial. And based on the CT, I would also like to assess the length of the membranous septum on CT in such patients, particularly to avoid or to prevent going into complete heart block during the procedure.
So you don't think you will put a pre-procedure permanent pacemaker?
For every right bundle branch block, I won't. I think it's better to avoid, because pacemaker has its own complications, pacemaker its own issues, and is associated with prolonged higher mortality in such patients, particularly if the patient is young. Okay. What approach, Dr. Ajay, sir?
No, I think we need to individualize the approach. The presence of right bundle branch block always is a very, very, very important confounding variable. And the pacemaker rates in patients with pre-existing right bundle branch blocks are of the order of 35 to 50%, depending on, as you said, the membranous septal length and what kind of. Looking at the CT scan, and if you don't have too much of calcium on the one thing I wanted to add to Dr. Parbinder's excellent talk was, if you have a lot of calcium on the membranous septum side, even if you end up with a lesser depth, sometimes the risk of pacemaker is a little high, because the whole calcium plate ends up compressing the conduction system and you end up with a pacemaker. So if you can assess that and you think that your chances of pacemaker are not very high, you probably don't need to put the pacemaker. In case you've got a short membranous septum and you have got a lot of calcium there, and you feel that you will not end up, or your depth is going to be around 3.5 to 4 for other reasons. Sometimes you need a coronary access to be available, so you don't have a shallow implant anyway. Those are other considerations. In that case, I would not be averse to putting a pacemaker in advance, although I wouldn't like to do that every time. But you can easily stratify such patients. So that is my basic point, is that. So in patients who have got, in all this, the most important thing is the survival of the patient. We are concerned, our mean survival in India is about 68 years. The mean survival in the Western world is around 79 to 80 years. Although their criteria was 65, that's because they expect just one procedure after 65 before the patient succumbs to his illness again. And doing a TAVR and a TAVR or a SAVR surgery in the first place becomes doubly, more complicated. So somebody with a small annulus or somebody with surgery, there's no doubt at all. And I completely agree with cardiology is taking, but we must remember to have balance in the sense that it's important to think what is going to be the long-term outcome in this patient, not just a short-term outcome. And if you're going to looking at a second implant of a valve, it's a little bit ahead and plan a little bit ahead for what this patient's natural history in his life is going to be. If one has got ability to do a of just one implant later, in that case, it's perfectly all right. But in case one is not sure that one will get a very, very good commercial access, then you have to think very hard whether you should be putting a TAVR in a very young patient. And this I'm saying after having done this for the last 7, 8 years. This is an important consideration to have. And I mean, the discussion started off from the pacemaker. So in one line, my answer would be stratify the patient. If you think there's a high chance, I would still think about putting a pacemaker up front if I'm sure it's going to require it. If not, I would put this and then decide.
Dr. Bali is here. Sir, good evening.
Hello, good evening. Can you hear me?
Yeah, yes, sir.
Yes, sir.
Yes, sir, we can hear you, but we do not see you. You're watching Shubman Gill's batting or what?
Yeah. But I think this talk was much better than Shubman Gill's innings and very exhaustive. And I enjoyed every bit of it. Beautifully covered. I don't think he has left any great areas for addition to his talk. Beautifully done, Parminder. I am absolutely mesmerized by your talk. Take care.
Thank you.
That's high praise.
Sir, can conduction system pacing be of help in patients in whom we are afraid of pacemaker very much after TAVR? So is physiologic pacing going to change the scenario? The way physiologic pacing is showing such a good data. So in patients in whom we have to use a supraannular valve.
Dr. Parminder, you would like to answer that?
That's a very valid question. I think, I don't know, because I think there is no data on that. Although,
Dr. Parminder, you would like to answer that?
Hello.
Yes,
Hello.
sir.
Yeah, he's responding. He's speaking. Yeah, we are hearing you, Parminder. Continue.
Yeah. I am not really sure, Saujatya. I think you are the better person to rather answer this question. Regarding the physiological pacing after TAVR, I think we don't have data on that. Although the pacing that we normally do, the data on that is not really that good in long term, particularly in young patients. So that's why I'm a little bit reluctant to go out with the permanent pacemaker in such patients. If it's avoidable, it's better to do that. But a role of physiological pacing after TAVR, I'm not really sure. What your opinion, Dr. TP Singh, on that?
No, I think it's evolving, and we'll wait for the data. So if the patient needs a pacemaker, then what options we have, what can we do? So
that's right, yeah.
Hello? A little.
Hi, Smit. Hi.
Yeah, Ajay, we can hear you.
Unstable. Am I audible? Dr.
Yes, you are audible. You are audible. You are audible, Smith. Hi.
Sir, sorry, I could not
evening.
join because of some network issue. And
Yeah,
this was one class that I was very desperate to join. We did a TAVI yesterday, sir. The lady had come, presented to us with Synco, and she had a sinus bradycardia, probably a 6 sinus syndrome because she had intermittent AF. So we initially thought that she needs a pacemaker, and we evaluated her for with Holter. Incidentally, we picked up that it's severe AS that is causing. So yesterday we did her TAVI. Now today we haven't put her on a pacemaker.
Okay.
So initially we planned that we'll put 1 or 2 millimeters, but then we thought that she would be requiring a pacemaker anyway. So we'll deep down we deployed it around 4. And it was kind of a tubular LVOT, and
That's great. That's great.
After deployment, she's having a sinus rhythm.
Oh.
So now I'm confused that today I had pulled the TPI back out,
Yeah.
but I do not plan to implant a pacemaker now.
Yeah, what I feel is like,
wrong?
yeah, you are absolutely right. It's really nice to hear that your patient is doing well. What I feel is that I don't know whether you do telemetry in such patients after TAVR routinely.
Sir, prior we had a Holter done for 5 days. She had bradycardia of as low as 40 with ventricular escapes, but she never had any syncope, anything.
Because after TAVR,
totally asymptomatic.
All right, because after TAVR, what we routinely do is 24 hours telemetry or 24 hours Holter should be done. Because sometimes,
yes, sir.
After
she was
TAVR,
on
post
monitoring. Yes, post TAVR, she was on monitor.
All right.
And we recorded, and it went down to 40, but she was never symptomatic.
That's
Prior to implant, we did a telemetry Holter for 5 days, continuous 5 days. She went to 38, 40, but never had syncope.
But I think she will be requiring a prolonged monitoring after the TAVR as well, because there are chances after a few days, something they go into complete heart block. There are patients with this kind of high risk, like you said, tubular LVOT, and so you need prolonged monitoring.
My thoughts on it is that she has a sick sinus syndrome and a very good ventricular escape of 40.
So if you think she requires a pacemaker, I think it's better to do it upfront, like or do it now. If you think it's otherwise, as Dr. TP Singh has rightly said, I think she should go for prolonged telemetry at home or something like that, maybe 7 days or 10 days telemetry, which may really show, because sometimes bundle branch blocks, heart block may be delayed, or it can even happen up to 30 days. So it's better to do a prolonged telemetry or put a pacemaker upfront as you feel, if you feel she really requires a pacemaker. What is your take on that, Saujatya? Well, you are also into EP. I think you can be a better person to respond to that.
I'm not that much into EP as such, sir, but I think finances available. If it is available, I think telemetry for 14 days, those things we can do. I think the other telemetry that things like internal loop recording, there I think impractical in our situation. So all that we can do is that external loop telemetry. So and follow up accordingly. Yes, sir.
Fortunately, I think internal loop is no more there with Medtronic is not doing it in India, at least. I had inquired about it. So
Senjude has one.
Loop, implantable loop recorders are not there.
But Senjude has got one, Reveal XT.
Yeah.
Okay. But
Senjude has got a Reveal XT.
External one is available where with a company called Web Cardio. So they do it for 5 days, 7 days, 21 days, and 3 months, like that. But it's an external device. It sticks on the skin, and I think they change it every 21 days.
Yeah.
Okay.
Hey, Dr. Smith, the ILR is available. The Reveal XT is available. I just have one question for Dr. Parpu. Sorry, I'm interrupting. Please go ahead.
This lady was already on Web Cardio for 5 days.
So that was pre-procedure. So
pre-procedure.
It's post-procedure, I'm saying. She will be requiring monitoring for a long time. If you are not putting the pacemaker now.
Well, I'm 50-50, sir. I thought that I should put a pacemaker.
No, but now if she have decided not to put, then she should go on for long monitoring.
Sir, about can I ask one question? About sinotubular junction calcification. So, is there a degree of calcification or arc of calcification which determines whether you choose self-expanding valve or not to go for self-expanding and go to balloon expanding? Because I think it should. I'm not very sure, but the supraannular frame should cover the sinotubular junction and go above it. So why should there be a risk of dissection?
Yeah, what happens is that, like, if you have using a balloon expandable valve in such patients, if you have to use balloon expandable valve in such patients, then the balloon of the size of the balloon should not exceed the size of your STJ.
Okay.
It's better to underdilate in such patients rather than do a proper dilation, because the balloon expandable valve invariably extends into the STJ when we do pre-dilation. So that number one is that possibly can cause dissection in the ascending aorta. So in such patients, if you have to use a self-expanding valve, it's better to use a valve, self-expanding valve with the low radial force. If you feel like that is with annulus, there is no much annulus calcification, because the like valve like accurate neo or something, it's okay with mild to moderate calcification, but for severe calcification, it's not a very suitable valve, because again, it doesn't oppose well, and there is a lot of PVL in such patients, and that's again an issue. So we have to weigh. It's like not like one way. We have to combine many features to reach at a conclusion which valve is best for which patients. Presence of STJ calcification, isolated STJ calcification doesn't preclude the use of, I think, self-expanding valves. We can, depending upon the other things also, like what is the sinus width, what is the height of the STJ, what is the sinus height. I mean, so many things do matter. Yeah. Usually, if you with STJ calcification, you have calcifications of the ascending aorta also. So, or severe calcification of the annulus or LVOT calcification, that will decide which valve is best for which patient. In general, we avoid a larger balloon in such patients during balloon expandable valves. So recently we did this patient that we did, we denied like TAVI to one patient because of the presence of STJ calcification. TAVI with because the balloon size which was available was the size of the annulus was 32. And it was not permitting dilation to 32 millimeters because the annulus was, the STJ was smaller and calcified. So we really couldn't do a balloon expandable valve in that particular patient. Because it will invariably, if the balloon is larger, it will cause dissection. And if you have aortic dissection, the mortality is very high.
Yeah.
Got it, sir.
Dr. Parminder, do you have any basilica, and how do you choose patients for basilica? What are the and height and other things which you take?
I expected this question from you, sir. But sadly, I don't have answer to that because I have no experience in doing basilica. There is one person who does it in Manchester. At our center, I think there was no particularly trained person for basilica, so I have no exposure to basilica personally. Although I think you are the best person for that.
No, I think maybe Ajay can throw some light on that. Is Ajay around, or he's also seeing Shubman Gill's innings?
No, sir. He's around. He's around. To be honest, I have no experience with basilica either. And, all the approaches of the problem with the basilica is when it comes off, it looks very good. But, I've seen sometimes it goes horribly wrong, and then it's a little bit of an issue. Essentially, in patients in whom you feel that coronary occlusion or sequestration caused by the leaflets. And it's especially important for valve with valve, whether it is a TAVR in a SAVR or a TAVR in a TAVR. And I think this is something that all TAVR operators need to become familiar with, because in the next 4 or 5 years, there is going to be an explosion of patients who will have a TAVR failure, and no surgeon is going to be very keen to actually operate on them. So this is my target for the next year, and I promise you that in 6 months, I will be able to speak a little bit more about it, because I'm planning to learn how to do it. And
6 months, we have a lot of experience, and maybe the device would also become better. The other thing, Dr. Parminder, is what are your take on rupturing the annulus in a TAVR in SAVR?
Valve fracture, sir?
Valve fracture, yes.
Yeah, I think I am on that side. Actually, I feel if we can do that, if the valve is fracturable, it's better to do it, because the hemodynamics will be better, and we can, even the small increase in the size or the diameter of the valve or the area of the valve that we deploy is really going to make a lot of difference in the hemodynamics. if we can improve the hemodynamics, possibly we can prevent the structural valve degeneration in such patients. So particularly if the patient is young, if the patient is older, maybe 80 plus or something, I really won't care that much. But if the patient is young, I would be really in favor of doing a bioprosthetic valve fracture rather than just implanting a valve. And secondly, in such patients, I think it's better to go with a supraannular valve. Particularly, I think Medtronic Pro Plus is a good choice in such patients.
And you go with an Atlas balloon or anything else
Atlas
you use?
Gold.
Yes, sir. Yeah, we have
Atlas
some exposure. We have some exposure. We have done few valve fractures in Liverpool. There, either we use Atlas balloon or a true balloon is also available, which is also very good balloon. True balloon is one balloon which deflates in 3 seconds. When you deflate it, it's very short deflation time, and it's most of the cases in such patients are done under GA, because with that you can really control the hemodynamics. If we are planning if it is planned procedure, and if we are planning to do a bioprosthetic valve fracture, most of the times we will go out with a general anesthesia in such patients.
Great.
Just one point. So sometimes we need to use an ECMO. Because the Atlas Gold, as he mentioned, it doesn't deflate at all. It's very difficult to deflate. It takes 15 to 20 seconds.
Absolutely true.
It's very difficult to deflate. And I think this, safest thing is actually to put a peripheral ECMO for that time. And then you're absolutely comfortable and you can finish the procedure and get away. Except for the trifecta valve, which cannot be fractured, whatever you do. And the second point about supraannular is fantastic.
Yeah.
The point recently, I think Dr. Murugan had posted a case where he had dilated a trifecta valve, and with a high pressure balloon dilatation, if it is not, you can't fracture it. Is it going to dilate it?
No, it's not.
Are we going to stretch it?
It's not, sir.
Fall back, or it will fall back.
It just doesn't make any difference. It doesn't make any difference at all. Bench tests have shown that you can take the Atlas Gold to whatever pressure you like. It just doesn't make any difference. In such a situation, the best thing is to put in the self-expanding valve and post-dilate to get the maximum area that you can in the place where the valve is being deployed, because it's in any case a supraannular valve. So that's going to be your place where you'll get the maximum area, and accept whatever stenosis you get in. If it is a trifecta, all the others can be fractured. But in my experience of 2, in one of them we put the ECMO and we were very, very comfortable. And the second one, we had a lot of problem because and the other issue with valve fracture is the risk of stroke is pretty high, and one must always use a protection device, because the amount of material that embolizes is not at all funny. It's quite a bit.
I think now we're getting surgical valves which are, going to be compatible with dilatation later on, once you do a tower in such cases. Or is it going to become a norm for all surgical valves to be amenable to a tower at a second sitting?
You absolutely hit near on the head, and the surgeons, sir. Absolutely.
I think as
network is not great, so I keep hearing in.
As TP said, that we need better fielders now. The surgeons have to start improving the thinking as well.
I tell my surgeon, जब Hindu riti में शादी होती है तो the boy moves half the circles moving ahead, and then after half the circles, 3 circles or 4 circles, the girl starts moving. Same way it has happened with cardiologist and CTBS.
Good one.
It's our turn now, is it?
No, but I think what has happened is even the surgical technique has improved, and that has been forced by the interventionist trying to stretch or extending the paradigm, extending the envelope. And that's why you see better surgical technique. If interventions had not pushed them so much, they would probably still be putting venous graft and doing whatever PPM they were doing with the aortic valve replacement earlier on.
Yes,
so
absolutely.
Surgical techniques have also improved. So keep the pressure on. Keep the pressure on.
True, yes, sir.
Just one last thing, Dr. Parminder, what is magnitude of the mortality caused by the pacemaker that we do place in case we do put?
Sorry,
Magnitude of the mortality.
Sorry, say that again. Sorry.
How large is the effect on mortality in a patient who undergoes pacemaker after a TAVR, caused by a conduction block after a TAVR? Does it actually change mortality much?
I think there is a data on that. I may not be able to tell you the numbers, but this mortality, long-term mortality is significant, particularly if the patient receives pacemaker after TAVR. That's the basically the reason that we are really concerned about avoiding a pacemaker. And I'm not able to tell you the numbers exactly, but mortality is, I think, significant after long-term mortality is significant.
Yeah.
What your take on that? What do you think?
Yeah, there is data that there is increased mortality in the home.
No.
But on the
I
other
was
hand,
asking for the.
on the other hand, where there are increased chances of that has shown some sudden deaths also in some patients, and probably this is the complete heart block or something like that which has happened. So that's why those who are borderline cases, either we should do the prolonged monitoring. So it's becoming a double-edged sword, I would say.
No, there's actually there are two kinds of patients who undergo pacemakers post-TAVR. One is the group who actually undergo structural damage to the bundles, and they are the ones who require pacemaker for them to, kind of, they are the ones who are slightly negatively impacted, and that number is actually much smaller. The second group is those who undergo pacemaker, but at the end of an year, less than 10% of them are actually pacing. And this second group, there is no change in mortality. The magnitude of mortality difference is actually not very large in patients who undergo pacemaker. It's more due to the cost. So the size of the benefit or the size of the downside is mostly related to the cost, not really related to so much to mortality, except in the small group who actually undergo damage. And in them, there seems to be something else which kind of negatively impacts the overall. The data is very much confused by the risk stratification in which this occurs, because in the high risk, there's actually no difference in mortality, which is surprising. It's in the moderate and the low risk, and it's more of morbidity rather than mortality benefit. So if you see the last, but now techniques have become better. In my last 35 cases, we haven't had a single maker, and I'm talking about this is the Evolut experience. So we are down to, with the cuspal overlay, I think that has changed quite a bit. But having said that, in a patient who requires it, we are not really very worried about putting in a pacemaker when you're spending so much of money.
Okay, yeah.
Yeah.
Thanks, yeah.
I think we had a super session.
Yes.
Fantastic talk.
Dr. Parminder there, sir, it was expected.
Really great.
Thank you so much. Thank you so much. Thank you, Smit. I just congratulate you and thank you for this wonderful academic opportunity you are providing. And it's really, you are so energetic. So, you are a true leader, actually, I would say.
It's all you have inspired, sir. So,
Baba Smith ki jai ho.
Only request is that do keep joining.
Sure, yeah.
Yeah, I think more and more people should join.
So now Saujatya has taken the reins, sir. So next topic we'll soon know from him what would be the next topic.
Right.
So,
that's great.
Will tell me and I'll do accordingly, sir. I have not taken over the reins. जैसे आप कहोगे वैसे ही मैं करूंगा सर और कुछ नहीं
नहीं बिल्कुल सबका प्लेटफॉर्म है सर it's a thing. So other things that we are planning, sir, registry and Bali sir is there, so the quarterly journal, sir, I was thinking that why not unveil the first copy in the July meeting, sir.
Oh, I think I make an appeal to everybody to start sending their articles and their whatever review case reports. Yes. If somebody wants to write anything else, review some trials or whatever, so please start sending it. July may be a little easy. And two more announcements I would like to make. One, our meeting is on 8th and 9th of July, and all the PGI are invited there. And we are planning, in addition to the academic thing which we will be having, We are planning a cricket match on the evening of 8th, and it will be interestingly PGI versus the rest of the world. Yes, you heard it right. PGI versus the rest of the world. So start putting on your pads and start doing some practice, and we'll have the match under floodlights in one of our stadiums. And all
Parminder
of
will
you
be
are
playing from
invited.
PGI. Parminder will be playing from PGI.
Yeah, Parminder will be there, and you will also come over. What's the problem? Okay,
No, I will definitely.
So I earnestly hope that all the PGI people make it to the conference, and it is basically we want PGI to be here, and we
Yes,
may
sir.
have meeting also.
We'll try that, sir. Yeah, I will be there, of course.
Yeah, look forward to each one of you.
Yes,
And, and anyone has any suggestion about the conference or any more faculty or any speakers to be invited for that, both at the international level and national level, please do inbox me or mail me or send a WhatsApp, and we'll take care of that. And I guess for the, I don't promise that in July we'll have it, but on the 1st of August, definitely we'll have a magazine out of this responsibility which I've been given, and I humbly take that responsibility. We should have a regular magazine, maybe.
Let's start with 3 monthly and then.
Absolutely.
It can be online. I can have designers. I can design it.
Sure. Please go ahead. And now we'll take it up. Great talk, Parminder. Loved every bit of it.
Thank you, sir.
Right, sir.
Thank you, sir. Thank you, Dr. TP.
Right, sir. Thanks, Dr. Parminder. Thanks, Smit. Nice seeing you, Saujatya. Good night, sir. Good night.
Thanks, Mother. Good night. Good night, everyone. Thank you.